Support for this podcast comes from Bryn Mawr Communications. BMC produces a number of informative podcast series spanning a variety of topics in ophthalmology. Discover a new show at itube.net/podcasts.
Welcome, everyone, to the Four Eyes podcast, brought to you by Young OD Connect. We give you a clear view into the young optometry world across Canada and the US. And we're your hosts. I'm Dr. Amrit Bilku.
And I'm Dr. Deepon Carr.
We have a very sneezy Dr. Carr today.
I know, it's my allergies. I'm not sick. I was at work today and everyone was asking me, are you sick? And I'm like, no.
I know.
My allergies are really bad, even though it's fall and there's no pollen. But I'm also allergic to my dog, which is sitting right next to me. So it might be his dander just floating into my nostrils. But I don't know. Anyways, so if you hear me sniffling, I apologize if that's on audio. But maybe that's some ASMR for some of you people. I don't know.
Well, it's just funny that you're the sneezy one because today Deepon is having the spotlight because she is going to be sharing some really interesting cases that relate to uveitis. So I just found it hilarious when we started recording that she started sneezing and I'm like, well, let's see if we can get through this one today. The one time you got to carry the episode, Deepon.
Sneezing and sniffling. I'll be sneezing heavily a few moments, but you won't hear those because we'll edit that out.
Yes.
But it's okay. But yeah, no, I wanted to talk about uveitis today, more about the basics of uveitis, and more specifically about anterior uveitis. I just had a couple of cases recently. Each of them presented a bit differently, and I just wanted to go over the basics of the condition and give like a brief overview of like signs, symptoms, treatment, and management, and tips on charting for these certain kind of patients.
Yes.
I feel like as a new grad, you know, we learn about uveitis in school and there's like, you know, this is how it presents. This is what you do. A, B, C, you're done. But in clinic, it doesn't ever show up that way.
Yeah.
And uveitis can take a wrong turn fairly quickly. So every time I get a uveitis case, I get pretty, like, not as nervous as I used to be, but I'm like, okay, you know, we
like,
gotta...
let's make sure it doesn't go downhill.
Yeah.
I still always have a little bit of that anxiety and panic when the patient comes back for the follow-up. I'm like, did I do the right thing?
The follow-up, I'm always like, crossed fingers. I'm like, oh God. Or, you know, you tell them come back sooner if something is worse. Yeah. And if you know, sometimes you see that patient scheduled a little bit earlier than your follow-up and you're like, no.
Or it's like get like the stress-induced uveitis ourselves. And then we can't see and we're like, I can't look through the slit lamp. I'm getting my own.
Yeah. So, you know, like, again, like the diagnosis and management of uveitis can be tricky for multiple reasons. The disease has variable presentations and patients sometimes provide an incomplete history, which is a very common thing. I feel like that happens, or they're very difficult to examine because they won't open their eye all the way, especially on kids, right? So if you have patients that are super light sensitive, they're not going to always listen to your instructions.
Yeah.
And also I've had some patients that were misdiagnosed with uveitis, you know, prescribed all the drops and everything, but they actually had something else. So that's another thing we can kind of go over. So again, starting with the basics of uveitis, right? It's inflammation of the uveal tract. Obviously, that includes the iris, the ciliary body, and the choroid. And the signs and symptoms will start to show once there's a breakdown of that blood aqueous barrier, right? And anterior uveitis is restricted to the iris and the anterior part of the ciliary body. So nothing really occurs in the vitreous or the retina. If you start seeing signs there, it's time to refer. Scream and then refer.
Yeah.
It's like, but yeah, like, you know, like patients with anterior uveitis, you know, what are the usual complaints you'll get? Well, even like they just come in with a red eye. You'll have some
Yeah.
on your schedule. Your staff is like, oh, you have an emergency. There's a red eye, which is
Yeah.
like
It's like, how
so
do you
many
know?
different things, right? So in my head, because this last weekend I was working, and for this last Saturday I had 4 red eye
Oh my
emergencies,
God.
and in my head I'm like, okay, and the staff just books them in and quickly asks them a few questions. Nothing like it's just quick, like, okay, what seems to be the problem? And then the patient's like, oh, I have a red eye, but they don't talk about like, what was their pain or whatever. Can you see
Mm-hmm.
whatever? Right? They just book them in, especially if we have the space for it, which we did that Saturday. So I had like
Yeah.
4 back-to-back red eyes.
Jeez.
And I'm like, oh my God, this day
Like
could either
a
be
it's like
really
a
long or okay.
it's like a KMK day all over
Yeah.
again.
So I was like, okay. So, first of all, like what are the differential diagnosis for red eye, right? We can,
Oh my gosh.
obviously
So
anterior
many.
uveitis, keratitis, corneal abrasion,
Viral
conjunctivitis.
conjunctivitis. Yeah.
Yeah, like all
Bacterial.
scleritis. The big
Yeah.
one is that I'm always worried about is acute angle closure.
Mm-hmm.
I'm always like, oh my God, hopefully, they
Yeah.
don't have a headache or they're not like nauseous
Yeah.
or something like that. Their pressures are not like 45 or
Yeah.
whatever. So, yeah, but then also one of the cases I wanted to start with, I had a patient who came in first time, also didn't speak English, so we were
Mm.
actually communicating through Google Translate.
Yeah.
Because he
That's
spoke,
rough.
yep, so he spoke Ukrainian. He's
Mm-hmm.
like a 40-year-old male, 42 maybe. Literally came in, vision was 20/20 in each eye,
Mm-hmm.
did not complain of any pain, and just
Mm.
was saying, I think there's something in my right eye. It
Yeah.
just feels like something's in there. And this was maybe like this was not this past Saturday. This was like a couple or a
Okay.
month ago or something. So I'm talking about this particular case then. But yeah, so he was like, yeah, it just feels like something's in my eye. He's like, my vision is fine. I don't feel any pain. He's like, there might be a little bit of light sensitivity, but he's like, no. And this was all through Google Translate. So he's typing
Yeah.
through Google Translate. I'm typing back and we're, talking this way. And then I, put the fluorescein in, check all of that. He had like maybe like minimal diffuse SPK on
Yeah.
his right eye.
Nothing
So I was
crazy.
like, okay, I think this is, regular dry eye. I was like, you can do some drops, some artificial tears, because he's like, oh, I haven't done any drops or anything.
Mm-hmm.
Yeah, he's like, and he just kept on saying, he's like, there's nothing wrong with my vision. Like my vision has always been good. There's no
Mm-hmm.
problems. And I was like, okay, well, and the redness around his eye, it was very minimal
Like
injection,
trace.
like
Yeah.
very trace. Like it wasn't that typical, circumlimbal
Angry red
injection
eye.
you see
Mm-hmm.
or really red. It was very minimal. So again, like even when you're checking, I am looking for any cells or flare or anything like that. I swear I didn't see any. So I'm
But
like,
I agree with you. It's tough too because especially we all have had those moments where when you already have kind of made an assumption of what the
yeah,
diagnosis is, you're really just digging for findings in those areas of the eye. So if you
yes,
already think it's going to be dry eye,
yep,
you're not going to spend 15 minutes looking in the anterior chamber,
yes.
right? Like
So
you're going to just kind of scan
mhm,
through it and be like, "Yep, looks empty." Look, like I wouldn't blame you for that because I would do the same
exactly.
thing.
So that's a really good point you bring up. I
Yeah.
think yeah. So this is kind of some of the patterns I feel like when you've practiced a little bit, not that we've
Hmm.
practiced for like 10 years or anything, but
Yeah.
we've gotten into these kind of patterns like, okay, they explain the history, and he wasn't on any medications or anything, never
Yeah.
had any issues like this before, whatever. Like really, really simple
Yeah.
history, right? And his vision was 2020, didn't talk about pain or anything, right? So in my head, I already categorized it as like, this is some sort of dry eye that's going on, right?
Yeah.
So yeah, exactly what you said. You're kind of looking for those kind of signs. And yes, like scanning the anterior chamber, yeah, I didn't again spend 15 minutes or like
Yeah.
really like, okay, where's that one little
Yes.
cell I might see, right? So in my head, I'm like, yeah, there's no cells in flare. Like this is dry eye. So I just told him, you know what? I recommended some drops from our clinic. And he was like, great, no problem. I'm going to get the drops. I'm going to do this 3 times a day, whatever. But I did tell him, I'm like, just letting you know. And I tell all my emergency patients this, if anything becomes worse,
Yeah.
you're losing vision, the redness is becoming worse, your eye is swollen, you can't like open them the next day. Come back to me. Come back to me. And they're like, okay, sounds good. I didn't do a follow up with this guy. I was like, okay, this should like heal up in the next couple
Yep.
days. So whatever. This was, I don't know, like one day, and then literally 2 days later, I see him in my schedule
Oh
again. And
no.
I'm like, what the hell is this? So I go to the staff and I'm like, what's going on? Why is this person in my schedule again? What happened? Because I'm still thinking it's dry eye, right?
Yes.
I'm like, it's not, maybe like he might feel some irritation in 2 days. Like, what's happening? What did he say? And they were like, oh no, he said his redness got way worse. And I was
Oh
like,
no.
oh. And they were like, yeah, like they say it's like, he said it was worse than 2 days ago. And I was like, oh, okay. So then in my head, I'm like, I don't know. Cause I've had quite a few patients too
Yeah.
that have come back with, yeah, like,
Yeah.
if you know, you
Sometimes
know.
if you
Like,
know, sometimes you'll get some patients who like kind of over exaggerate what their symptoms are like because they just want to see you,
yeah,
they want confirmation, they want
yeah,
reassurance, and then
yeah,
yeah, and they will make it sound very worse over the phone so that they
yeah.
can make sure your staff squeezes them in that day. So
Mm-hmm.
I do
So,
the same thing. Sometimes I'll ask the staff more questions like, did you also ask about this? Did you ask about
yeah.
this? Like, is this really something I need to see 2 days later if I assume it's
Yes.
dry eye versus can they push it to next week,
Yeah.
right?
So
So
I
like,
I did
yeah.
mention this to my staff too. I'm like, is there like was there anything specifically said over they just said the red eye got worse. And I was like, okay,
Mm,
maybe then in my head I'm like, did it actually get worse or did it just
yeah.
not go away? Right. So I was in my room, he comes in, they're doing the pressures and everything, and my staff or my technician comes in and I just ask her bluntly, I'm like, how red is it? Is it even bad? Like, tell me the truth. And she straight up says, it's bad.
Oh,
She's like, and she's very like, oh no, there's no red eye.
yeah,
This is
yeah,
this is
yeah.
gonna happen. She's like, no, Dr. Carr, it's
It's
like pretty
bad.
bad. And I was like, oh shit. So I was just oh no, what is this now? Because I'm like, oh crap, this is not just dry eye then. Like maybe it's like maybe it was a pink eye or something. Then I was like, but he didn't really mention any discharge or anything. So now I'm
Yeah.
going through these like
Yes.
differentials before I see him. And the other part of it, he doesn't speak fluent English. So
Yeah.
we're
Yeah.
doing all this through Google Translate.
Yes.
He comes in. I see his red eye a mile away, and I'm like, oh
Oh,
gosh, this is not. And then, but his vision is now 20/25 minus a couple letters. So he
yeah.
started getting
Things are
blurred vision.
changing.
And he even tells me, he's like, oh, Dr. Carr, my vision is really blurry. I've never had blurred vision before. It's kind of foggy. And I was like,
Oh,
oh. So now I'm like, oh no, did I miss a uveitis case? So
yeah.
then he sits in my chair and I put the fluorescein in. I just check again. Like not really much SPK this time. However, yeah, the cells and flare have exploded. So I was like,
Yeah.
okay. So
Christmas came early.
yeah, so yeah, there was cells and flare there. I was actually surprised his vision wasn't worse.
Yeah.
I thought it was going to be like 20/40. His pressures were lower or normal
Yeah.
still, but I mean, like I was gonna say the typical symptoms that we're taught in school about anterior uveitis is blurred vision. Pain is a big
Hmm.
one with red eye. Anyone
Yeah.
who says pain with a red eye, you instantly think, okay, this is likely uveitis.
Yeah.
Like glare sensitivity, they'll say there's a red eye, and there's like that conjunctival injection, but
Yeah.
pretty obvious. It's not like a minimal
Yeah.
injection or
Yeah.
that circumlimbal injection. That's the typical sign
Yeah.
that you'll see. And then they don't usually talk about a watery or mucousy discharge or
Yeah.
something like
You're
that.
right. I don't really hear a lot of my eyes watering. It's more,
Yeah.
it's just light sensitive. There's a dull ache around my eye.
Yep.
And then sometimes, yeah, my vision just it doesn't feel as sharp as the other eye. Sometimes
Yeah.
it's so mild that they can't explain it's not a blur, but it's just
Yeah.
like it just looks a little cloudy or a little less sharp than the other.
Yeah. And this guy, like, he's always had clear vision, so he told me right away. He's like,
He
it's
can
not
notice
clear
it.
anymore. Like,
Definitely.
there's something wrong. And I asked about pain, and he's like, I don't feel any pain. It's just getting more red, and I can't see as well. And I was like,
So pain
okay,
tolerance is high.
yeah, but maybe yeah, he has a high pain tolerance. I don't know. So yeah, I mean, the hallmark signs of anterior uveitis is the cells and flare, right? So as
Mm-hmm.
soon as you see that, even a small amount, it's a form of
Yep.
uveitis, right?
Yep.
And again, we all know cells and flare are the white blood cells and proteins that are leaking from the uveal vessels, and then they're circulating in the anterior chamber, right? So
Mm-hmm.
that's what we're seeing. Um, obviously, like a well, just in case if people don't know, tip like the clinical tip with the hypopion, when you see that accumulation of white blood cells at the bottom of the anterior chamber
Mm-hmm.
cell, you want to treat that aggressively or send that out because that's a pretty severe form of
Yeah.
inflammation. I've actually never seen one of those in clinic myself.
Mm-mm.
I don't know how have you? I do know if I ever see one, I'll probably have a heart attack and be like,
Yeah.
what's going on? Oh no. But that's a pretty aggressive form of anterior uveitis. And then, so this was an acute form of
Mm-hmm.
uveitis, right? The reason why I'm just talking about all of these little minuscule signs is because this should all be charted because
Yes.
it's important, especially if there's multiple doctors in the clinic
Who are gonna see them
following
for
up.
follow-up. Oh yeah.
Which brings me to another case too. I know I'm kind of jumping around, but in his case, this was an acute form of uveitis, which happens suddenly. There's a sudden onset
Mm-hmm.
with a limited duration. So that's less than 3 months, right? A chronic form is it persists more than 3 months.
Mm-hmm.
And those are the people that usually tend to have higher IOPs because
Yeah.
this uveitis just doesn't go away. The
Yeah.
acute ones tend to have a lower one because the sorry, the what am I trying to say?
I don't know. I don't know anything
the,
about
the
uveitis.
liquid in the anterior chamber is not
The
flowing as
vitreous?
much. So it's not like the ciliary body is not making as much
Vitreous?
yeah, as much like that flow is
Yeah. Oh, like the flow within the anterior chamber
yeah,
has
the flow
slowed
within that
down.
tumor is not as much. So it decreases a little because
Got it.
it recognizes their inflammation there.
Yeah.
So they're like, we're just gonna slow this down. So it can be like, oh, their pressures are low. Like this might not be a uveitis or but that could be like a way to misdiagnose.
Yeah.
And then recurrent uveitis is, there's repeated episodes separated by inactive periods
Yeah.
without treatment for 3 months
Yeah.
or more.
Yeah.
So it's important to kind of like diagnose that just so other doctors in the clinic or wherever their charts are sent or whatever,
Yeah.
they know what's going on.
Yeah.
So yeah, I saw the cells in flare, you know, grading it. Okay. I don't remember the charts that we had when we
I
were in
do
clinic.
not. I
So
grade based on just how many I see and what I think,
exactly.
what
Yeah.
severity level I think it is.
I
Yeah.
would strongly suggest even counting the cells or even saying there's more than 50 because
Yeah.
the other case I had, there was two of us managing this patient who had a recurrent uveitis. So
Hmm.
she had an episode like in January and then it went away in February and then it reoccurred again in like July or something like that. So
Yeah.
and then now there was I managed her the first time in January, good, gone, whatever. And then it came back and now there was two
Hmm.
of us managing it. And let me tell you, I'm sure when we were reading each other's charts, like it was just
Yeah.
like, is this getting better? And I would always ask the patient, I'm like she was on her prescription drops, right?
Yeah.
And she was like, I think it's better, but like we would check her vision. Her vision was kind of staying stable, but I
Yeah.
couldn't tell if the cells were
Yeah.
decreasing
Going
and the
down.
flare was yeah, because now it's becoming so minimal. I'm like, well, now I see like 5 cells. Did the other doctor see 5 cells? Like,
Because
is
like
this
if we just grade it like a +1, then
Yeah.
it's like, well, how many are you grading
Yes.
as a plus one if we're not
Exactly.
following the same scale,
Exactly.
at least within the office?
Yeah. So
Yeah, you're
I
right.
prefer the number of cells, like more than 25, less than 30 or something like
Yeah,
that.
yeah.
And the flare, there is a chart. I mean, this is hard to remember too. It's a chart by the standardization of uveitis
Mm-hmm.
nomenclature, the Sun Working Group. So they say, so yeah, as we said with cells, just say the number in the anterior chamber or make your
Mm-hmm.
best guess instead of saying the grade like 0, 1, because really nobody
Yeah,
knows
everyone's
or
judgment's gonna be
remembers.
like different.
Yeah,
Yeah.
exactly. For flare, grade 0 is none, 1 plus is faint, or 2 plus is moderate, where the iris and the lens details are clear. That's something else you can
Mm-hmm.
say for flare. Say, like, this
Oh.
is flare, but the iris, like, this is my grading for the flare. I can see the iris and lens detail clearly. 3 plus is
Oh.
considered marked, but the iris and lens detail is hazy. And then 4 plus is nah,
Can't
intense. I
see
can't see
anything.
anything. So there's
A
like
thick cloud in there.
nothing is visible. So
Oh,
I
that's
would,
helpful.
yeah, I would use descriptive um charting like that so that whoever else sees the chart, they're kind of like, oh, so they were able to see this last time. What am I
Mm-hmm.
able to see this time,
Yeah.
right? That this is totally different if you're the only one managing the patient,
Yeah, of
but
course.
most of the time with these uveitis cases, like if there's multiple doctors in the clinic, someone else is going to
Yeah.
be managing it, right?
And I guess if you're fortunate enough to work in a clinic that has anterior seg camera, I know it would be really hard to
Yes.
take
Hmm.
photos or videos of the cells in the chamber, but if you're able to, I mean, that would be gold, right? Because we have an anterior seg at Northern Site, a
Nice.
camera. And so anytime I see a red eye, a uveitis, anything, and if I know Manraj is going to see that
Hmm.
patient the next time because I'm not there, I take photos and I turn the camera on and I try to take photos because yeah, I'm not the go-to doc for a red eye. So like my grading scale is very
You're like,
subjective, right?
yeah, I
Like
think maybe
it's
five.
red.
Yeah,
That's
there's
like
something going on.
there's something there. No, no, I'm totally joking. I know how to handle uveitis, guys, but yeah, I don't see it every single day. It's not in my chair
Yeah.
all the time. So, my grading scale is very just like, yeah, plus one cells.
Yeah.
Like that's or if I just see three cells, I'm just gonna write three, but most of the time I use plus one, plus two, plus three. And so with the camera there, it makes all the difference. If you can take the pictures
Yeah.
on an iPhone, that would be
Hmm.
like easy too. Just upload it in their file. Take a
That's true
picture of
too.
their eye on the outside, just so you can see how much redness is there.
Yep.
Yeah, that would honestly help if you guys had that too.
Yeah, and like, yeah, that's a really true. If you have a anterior side camera, yeah, I would try to your best to kind of zoom in and take a photo of what you're seeing. I think I like at my last clinic, I did have an anterior side camera and I was able to take some photos of like some cells if I zoomed
Yeah.
in enough. You just have to have the patient be really still and open up
Yeah.
their eye really wide. But that's the same
Yeah.
thing with an iPhone camera as well. But yeah, I mean, if you can show what it looks like for the next optometrist to see that, it's just better. It's just going to be better management
Yeah.
for this patient because then they'll know like, oh, this didn't improve or oh, this did improve or whatever,
Yeah. Yeah.
right?
Yeah.
What are your tips for seeing really faint cells and flare? Like I
Like how
like
to manage it?
well, no, like how like in when you have the slit lamp on them and
Yeah.
you're looking for any cells and flare, I completely darken the room. Like I turn off the computer monitor,
Yeah. Oh,
everything.
wow.
And
Yeah.
then yeah, because I especially if I'm really trying to remember how we talked about that categorization of like
Yeah.
conditions, if I'm like this has to be a uveitis or something. Yeah. And I'm like, if I am gonna see that one cell, I
Yeah.
need to like completely darken
Turn
the
everything
room.
off.
And the patient's like, oh, I can't even see my own feet
Yeah.
sometimes. I'm like tripping over the chair. I'm like, oh my God. And then I'll increase the magnification completely.
Yeah.
Like I
Yeah.
said,
Me
completely
too.
darken the room. And I'll try to dark adapt and kind of get used to that for the first 30 seconds. Not going to be able to do that very soon because I'm aging, y'all. But
Yeah. Every day that I work in the slit lamp, I'm like, dude, our days are coming. We're
yeah.
not going to be able to see. Oh
Oh,
my
like
God, I
my
think about
dark
all this
adapting quick
side
days.
story. Think, I'm much younger than Deepon, but still, I also think about that some days. I'm like, wow, one day I'm not going to be able to see through these oculars anymore.
Yep.
But no,
So,
I am very similar to you, except honestly, I turn off the room lights. I don't turn off the computer, so there's still some dim lighting in there. And
mhm.
then I do that like funny, like I guess old school thing, or what some of the lab like the doctors would show us in lab. Like I just like hover my hands over the
Yeah.
oculars and just
Oh,
try to
yeah.
like black out my eyes connecting to the oculars so that I get no light entering my eyes unless it's through. So that does help.
Okay.
Um, I find that I try to, so at first, I know when they're really light sensitive, I try to shorten the beam
Yes,
and
I
make
do
it
that
like
too.
a, like a 1 by 1 or a one by
Yep.
2 millimeter. And then if I'm not seeing any cells, I'll widen the entire, or I'll vertically widen the entire beam. So I just make it all vertical. Width-wise, it's still like maybe 1 millimeter, maybe 1.5 to 2. But I have to get like the whole cross section of the cornea at that point because I'm like,
Yeah.
where would this 1 or 2 cells be, right? Like,
Yeah.
so I have to
I
kind of
sometimes
really make
also
sure.
I'll get them to like look up and then
Oh,
straight
I
ahead
have
to
their
see
eyes
if it.
shake like a snow globe. That's what I tell
Yeah.
them. Yes, I'll have them look up for 2 seconds and then look back at my ear. And then
Yeah.
I'll kind of tell them too, because sometimes they're in pain and they feel uncomfortable. I'm like, all right, we're going to shake your eyes like a snow globe now. Look up for
Yeah, yeah,
me,
yeah.
look straight. That does help, honestly.
Yes.
Like, I found it so funny to do, like during school when we were taught that. But I have caught 1 to 2 cells in some people by just having them look up and then look straight
Yes.
because it just shakes the eye a little bit, gets them moving, and then you can actually
Yeah, and
start to
then
see
even
stuff.
like again, uveitis is should be diagnosed if you see even one
One
cell or
cell,
two
yeah,
cells,
one
right?
cell
That
or
is
trace
uveitis.
flare,
That is
yeah,
what it is, right?
yeah,
Even that could be the early startings of it. Like even for the first patient I was talking about, my Ukrainian patient, there was
yeah,
probably a cell in there, but I
yeah,
just didn't look at it closely enough, right?
yeah.
So, yeah, so that I do the same thing. I do like a 1 millimeter by 1 millimeter parallel pipette and then kind of
Mm-hmm.
scan the whole cornea. But I do take my time with it just to make sure I'm not missing anything.
Mm-hmm.
And like cells, yes, you'll see a couple sprinkles of those. Flare might not be there, but if there's no flare, then you know the ability to see that slit lamp beam all the way through the
Mm-hmm.
aqueous, it's going to be optically empty. Like there should be
Yes.
nothing, no haze,
You
nothing
should see
there.
no like light passing through it.
Yes,
Yeah.
exactly. Yeah, yeah,
Yeah.
yeah. So,
Wow,
yeah.
look at me, guys. I know my stuff. I know my ocular disease.
Yeah.
Sometimes I see
Um,
so many kids where I'm like, damn, I really don't remember a lot of the other
I know
parts
that's
of
why
the
you
eye.
got to go like just spend some time at I don't know, a really
An
medically
eye
heavy
disease
clinic and be
clinic.
like, like what is this? It's just like
My
it's just
anxiety levels
diabetic
would go,
retinopathy, Dr. Bilku.
my anxiety levels would go through the roof. Actually, I was gonna say okay, interesting question for you.
Mhm.
How, now, do you treat a mild uveitis with like 1 cell and ace and like basically asymptomatic patient? Do you treat that differently now than a more moderate to severe uveitis in terms of what you prescribe?
Oh, no, I'll still do the steroids
Yeah.
like a strong steroid every couple hours and follow up the next day
Yeah.
because I'm scared it's gonna, what happened to my first patient? Like there was
Yeah.
probably
Like
one
it got
cell there
worse.
and then boom, it like exploded in a
Yeah.
couple days. I don't want that to happen. So
Yeah.
I'll do a heavy duty steroid every couple hours.
Hmm.
And then if there's pain, I'll do cyclo,
Yeah.
cyclo or atropine
Yeah.
twice in both eyes, twice a day in both eyes.
Yeah.
Uh I don't really prescribe cyclo or atropine that often. I don't get a lot of uveitis patients that feel pain. They never really complain of
Yeah.
pain to me.
They're always like mild, like a dull ache, but like it's manageable
Yeah.
or they're more light sensitive and then,
Yeah,
they don't really feel the nausea or the oh my God, I have such a throbbing ache in my head. Like they don't really feel
exactly.
that.
I don't really prescribe that. So, and I
Yeah.
know, like, obviously with cyclo or atropine, you're dilated, right? And I feel
Yeah.
like, that will be very disruptive for
Yeah.
someone's day.
And more
Um,
uncomfortable too.
yeah,
Yeah.
exactly. But yeah, like the other aggressive sign too is like the KPs or the keratoc precipitates, right?
Mm-hmm.
So, you know, they're pretty important as well. If you see this, I've seen keratoc precipitates pretty
Yeah.
often
Me too.
with uveitis, and it just kind of again makes me a little nervous just a little bit because I'm like, okay, this can turn bad very quickly.
Yeah. Yeah.
Because then you're also wondering, which we probably will get into in a moment here, like what the heck systemically could be going on too.
Yes.
So,
Yeah.
as a general rule, right? Like fine, the star-shaped or stellate kind of keratoc precipitates
Mm-hmm.
are considered non-granulomatous inflammation and the non-infectious
Yeah.
etiologies. And then the larger, greasy,
Yeah.
mutton fat, oily
Yeah.
KPs are found. Those are the scary ones that are found in the, granulomatous uveitis. And like the mutton fat KPs are suggestive of some sort of infectious,
Mm-hmm.
toxic,
Yes.
chronic disorder.
Yeah.
If you see that, there's something
You really need to send
systemically
them
going
out.
on. Yeah.
Mm-hmm.
This is probably not the maybe first time they've had it.
Yeah.
And then pigmented KPs, they've already had a previous
Yeah.
episode of
It's
uveitis. So
old.
you're
So
kind of
it
like
gives you
you're
a
like,
hint.
okay, has happened to you before. We need to
Mm-hmm.
see what's going on.
Yeah.
Support for this podcast comes from Bryn Mawr Communications. BMC produces a number of informative podcast series spanning a variety of topics in ophthalmology. Discover a new show at itube.net/podcasts.
And then obviously, like with all these patients, you should do a dilated eye exam because you want to check if anything has extended to the back of the eye. You want to make sure you're saying what the location is, if it's an anterior,
Mm-hmm.
intermediate, or posterior uveitis.
Yeah.
Again, with posterior complications, I had a case of that, like not me, but another patient who had cystoid macular edema. And this was the first year I graduated. So I was panicking and I was like,
Wow.
what is this? And then, but I'll make it easier for you, everyone. Intermediate, posterior panuveitis, you're referring to the
Yeah.
ophthalmologist. So you're
Yeah.
like,
You don't have to
you
worry
have
about
something going
it
on.
outside in the real world,
Yeah.
at least not in Canada. So
Yeah. So
you don't
that's
have to
an
worry about it.
urgent referral. And most of these patients are gonna be like, I can't see anything. And
Yeah.
yesterday I was able to see. So you're
Yes.
like, bye. We'll
Yep.
see you
Send them
at
out.
your maybe follow-up.
Send them out.
Yeah. So we already talked about this. Like we treat, anterior uveitis with our steroids. We just said, yeah, you do every couple hours or what's your management plan?
I I have played around with a few patients who are open to playing around with their
Yeah.
treatment options. After thoroughly educating them on, what to do if it gets worse. And because I've had a handful, I get a lot of the more mild uveitis patients,
Yeah.
or I get a lot of just the recurring ones that
Me
come
too.
in like clockwork and they're like, give me my Maxidex, give me my Cyclo, it's happening again. Okay,
Yeah.
fine. And they know exactly what's going on. So and they all recover. So I haven't had any crazy, cases, thankfully, so far. The ones where the patient tells me that the symptoms sound more like a uveitis and I don't see any cells, or maybe I'll see one. And, I'll talk to them about, okay, I really think this is uveitis. I don't think this is a dry eye or conjunctivitis, whatever, whatever. But I'm not seeing a crazy amount of inflammation there. So I myself, I don't say this to every patient. This is just for you guys to know, but like I myself have self-treated my own uveitis at home with
Yeah.
ice cubes and like just like whiskey stones, like ice, like cold compresses, refrigerated artificial tears, and Advil. And my own
Hmm.
uveitis went away in about 4 days.
Okay.
And I self-monitor. Obviously, we're optometrists. I know what to look for and self-monitor. And yeah, it was painful, but with some ice that reduces inflammation, shrinks your blood vessels, slows down white blood cells from migrating to your iris and everything. And the Advil, anti-inflammatory med, brings down the pain, and cold, preservative-free artificial tears lubricates you, soothes
Yeah.
the cornea. You
Well,
know, if you're
that's
able to,
not
yeah,
like
it's not bad to do.
no, and the reason why is what I talked about before. I had I had a patient come in who was misdiagnosed with uveitis, and she was put on everything,
Yeah,
like
all the drops.
all
Yeah.
the drops, cyclo. So she couldn't
Yes.
see. So I couldn't even test her vision because she's like, I can't see anything because she's dilated.
Yeah.
She was put on steroid drops every 2 hours, yes. And she was also put on Maxidex too.
Yeah.
And then
Yeah.
she was given like artificial tears. So she came in, she went to another clinic 2 days before, and she came in and she was like, I don't know what's happening. Nothing's getting better. She didn't want to follow up with the original doctor, so she just came in as a walk-in to our
Yeah.
clinic. And I requested the previous reports from the other clinic because I was like, when I was checking this patient's eye, I did not see any
Any
cells or
cells.
flare.
Yeah.
I was like in her eye for like 20 minutes. And I'm
Yeah.
like, what in my head? And I didn't say anything to her. I was just like, am I missing something?
Yeah.
And I was just like, okay, I got to get the reports from the
Yeah.
previous doctor. And the previous doctor, I think she recorded maybe like 3, 4, 5 cells or something like that. Not a lot, but I don't think I'm not 100% sure if those cells were all there because I just couldn't see
Yeah.
anything.
Anything. And this was like 2 days later.
Yeah. And
From
I
the
was just like,
tube.
okay, like I don't know. Like maybe it's possible that it healed up that
Yeah.
quickly. But this patient now was freaking out because she also had keratitis, SPK, all
Yeah.
over her eyes. She was
Jeez.
dilated, so she couldn't see anything. She
Yeah,
had
of
to work on
course.
her computer all day because she was in school.
Yeah.
So she's like, I can't see anything. My eyes are still irritated. I'm taking these drops, they're not doing anything.
Yeah.
So I think, yes, like if you're seeing a few cells, you don't have to do the whole shabam.
I don't
Like,
think and you have to, so I educate them very thoroughly on this. If
mhm.
I know that this looks like a very mild case of uveitis, I ask all the questions, the case history. They have no medical history. They've never had a uveitis before. This is the first one. We know 50% of the time it could be
Yes.
spontaneous.
Yeah.
So then I tell them, I say, well, you know what? You got two options. We can try to treat this naturally for a couple of days and see how you feel.
Mhm.
And if you don't feel better, give us a call back within a day or two, email us, give us an update. And then we can definitely throw all the drugs on you and, like, make sure it heals up. But I have a feeling that within about 3 or 4 days, if you do your cold compresses every few hours, if you use the artificial tears refrigerated, take the Advil, Tylenol, yada, yada, I think within 3 or 4 days, you should feel fine.
Yeah.
And, I give the patient that option. And then I say, or we have the steroid, we have the cyclo drops, we have all of this. And, and then you still will do the cold compresses anyways. But it's up to you if you want to use the meds now or, give it like 2 days and then call me back and then we can see.
Yeah,
And
I
I've
think there's
had, yeah, there's
I
good,
don't I don't think there's anything wrong with that.
no,
I
yeah.
think that's fair, especially if it's such minimal cells.
And I've
You know,
had them
before.
come back within about 4 days being like, yeah, I'm totally fine now. And I
Yeah.
check them back. There's no
Yeah.
cells, there's no injection. Like sometimes I'm not anti-medicine, but sometimes I do feel like sometimes you just need to give the body some time, dude. Like
Yeah.
you need to just give it some rest. You
Hmm.
need to give it some cold compresses, cool down that body temperature, stay home from work. Like I always tell them, like, do not do your work. This could
Yeah.
be stress induced. Like sometimes you really just have to give a patient a chance to let their body kind of figure it out and heal. And you will be surprised at how many times people's
Yeah.
conditions will heal. For viral conjunctivitis and like so many times I've just been like, dude, just ice the eye, some preservative-free tears. I don't need to betadine rinse your freaking eye
Yeah.
every time. Like we don't need to do all those
Oh
things
my
and you'll
Lord,
be fine.
betadine rinse? When was the
Like
last time anyone did that?
I've never Manraj does it. Like he's
Oh
done it,
my
which is
God,
so cool.
Manraj.
I
What?
think it's
I
cool.
think the
Like
last time I heard about it was at my rotations, and even then I
yeah,
was
like
like,
I
"Meh."
like he was like, yeah, like oh, do you know where we can get some betadine? I'm like, huh? I'm like,
I'd be
I'm
the same way. I'd
like,
be like, betadine. No,
yeah. So I'm a
no.
little different, but I educate the patients on it, right? I'm like, here's the meds. If you want to take it today, here's the prescription. Go for it. If you want to
Yes.
hold off, do the more natural things, come back in about 2 days or three, and let's see what happens. And when you
Yeah.
see that person with like one cell, two, sometimes they really do heal. But I
Yeah.
feel like in your case, I think like I don't know, like I think for your case with a guy who had like one cell that you might have missed, I'm very curious too to see though you just said artificial tears because it's more dry eyes.
Hmm.
I'm curious if you added the cold compresses, the refrigerated artificial tears, and Advil. Like, and
Oh,
I,
yeah.
I
If it would have been
wonder,
better.
like, would it have slowly then come on, like
Yeah.
maybe a little bit
Little bit.
worse
But
versus
then I would
like,
have
an
completely
angry.
missed it. I don't know. Maybe he might have been like, came back like 2 weeks later and been like, now it's really bad or something. I don't know.
Well, yeah, then at least you could have slowed it down, which,
Yeah.
okay, cool, it lingers a little bit, but I mean, who knows how long it was there for prior?
Yeah. I don't
If
know.
he really has like
He did
very
say it
high pain
started
tolerance.
the day before. Because I remember he was like,
Okay.
oh, it just started. The irritation started the day before.
Yeah.
That's why I was like,
But you'd
yeah,
be
this doesn't
monitoring
work.
anyways. You wouldn't let
Yeah.
him go for like
Oh,
two
yeah, yeah, yeah.
weeks,
Because
right?
that's what I said. Like,
But I'm
come
very
back.
curious to see if you added that. I'm curious to see would
If it
he
would have.
have blown up like that
Maybe
quickly
not. I don't know.
over who
But
knows? I'm sure there's other underlying reasons why it got bad
yeah,
that
I mean,
fast.
he's never,
But
this was, I can't remember when like, this was recent when I saw him and he's never had anything come back
yeah.
yet. Like, I see his kids now and he's like,
Yeah.
my eye is still good. And I'm like, "Okay, good. He did. I'm like, good. And he'll
Thank
like show me through
God.
Google Trends, like, eye is still good. And I'm like,
Oh
that's
my God, I
good.
love that.
So yeah, like he's a really nice person. And I was just like, okay, yeah, great.
Yeah.
But yeah, like I think too, like with that patient, who might have been like misdiagnosed with uveitis. I
Yeah.
think it was more of a dry eye issue, like like an advanced dry eye issue she had
Yes.
with the
Yeah.
irritation and the redness. And then all the prescription drops that are usually used for
Yeah.
anterior uveitis was put on her. It just disrupted things more.
And obviously that will
um,
make your SPK worse. I mean, these meds
yeah,
are not soothing. Like I tell
no,
my patients that all the time because when they have the irritation from the uveitis, they'll be like, "Well, my eye's still burning." I'm like, "Are you using the preservative-free drop?"
yeah,
"No, I'm using the meds." Yeah, they're not soothing. Like they
yeah,
are meant
yeah. They're
to
not gonna, yeah,
scratch your eyes so they could get in there.
yeah,
Like they have the preservatives for a reason.
yeah. So
So they're not soothing anyways.
So yeah, we completely changed that management plan for that patient,
Yeah.
took her off all the drops.
Did you
I
just
think the
do like
steroids,
heavy artificial tears, like just for the
yeah,
dry
and
eyes?
like hot compress and
Yeah.
because the dilation was going to last for 48 hours. So I wanted to
Yeah.
follow up with her after 40 hours to
Yeah.
actually get an accurate view
Yeah.
of her or
PA
assessment of
measurement.
her
Yeah.
vision. So she was fine after that. But yeah, I mean, I think sometimes as new grads, we're taught to like, okay, you see this, you got to do this. But I think it's like also and not as I said before in this episode, patients don't always give the full history, but we
Hmm.
kind of have to drag it out of them.
Yes.
Like what you said, education is super important. Like if
Yeah.
nothing's getting better, come back, whatever. But
Let me add to that. Speaking
yeah.
of making sure you get the full history, oh, for any new grad out there, yeah, another thing that I brought up was that, yeah, 50% of your uveitis case on the first time is going to be spontaneous, right?
Mhm.
So we're told and taught that, you don't have to really dig in for blood work the first time it ever happens, especially if it's a non-granulomatous, anterior uveitis, acute onset, whatever. What I've learned in the past 5 years is that there's so many patients out there who have recurring uveitis
Mhm.
and you'll see them and you'll see in the notes from the previous owners and whoever else has worked there that they've come in maybe 4 times for a uveitis in their lifetime. And they'll even bring it up and be like, yeah, I've had this maybe once before, like 5 years ago. And then you ask them too, have you ever done blood work? No.
Mhm.
And they never do because there's a very good chance that every time they're seeing a doctor for their recurring uveitis, they're seeing a new doctor. So then they might not bring up the history and then they might not tell you the full story and then that doctor is always going to assume, okay, this is your first occurrence.
Yeah.
So we don't need blood work. And so what I've started to do is just totally disregard the 50% spontaneous
Yeah.
causes and just anytime I see someone with a uveitis, I send them out for blood work. Even if this
Mm.
is their very first time, if they have one cell, I say, why not? Go get your blood. It doesn't cost you anything in Canada to get your blood work checked. It's not harming you to get your blood work checked.
Yeah.
Just do it, even if it's the first time you've ever done it, because you need a baseline and there's still a 50% chance it's something else.
Yeah. Yeah.
So, that's one of my tips is just do the blood work every single time and every time because when it's recurring, if their blood work
Oh,
was
yeah.
clear the first
Yeah.
3 times, that doesn't mean it's going to be clear the next time.
Even
They could still have something underlying, getting
Yeah,
worse.
even if it's the second recurrence, like this patient
Do it
that
every time.
me and the other doctor was managing, this was her second recurrence, so I'm sending her out for
Yeah.
blood work.
Yeah.
Um, so yeah, like that's a discussion that
Hmm.
needs to be had. And you're right, like you mentioned this already, 50% of these cases when they happen for the first time, it's idiopathic, right? We don't know.
Yeah.
But like we also should be asking them like, do you systemically, is there anything going on? Like, do
Yeah.
you feel pain anywhere? You're thinking about the arthritis, I
Hmm.
don't know, like lupus, all these different things. And,
Hmm.
obviously when you're getting into those more like tuberculosis, syphilis, that's a little bit more, oh, they're going to notice that. Like there's
Yeah.
something,
Yeah.
there's other
Those are going
symptoms
to be
there.
big symptoms.
Yeah, those are going to be bigger symptoms. But I wanted to talk. Oh, wait. And before we talk about that, so I always say this before you um, start tapering the
Oh,
steroid,
yeah.
I always make sure that there is zero cells and fit flare before I start tapering, just because I don't want a rebound inflammation.
Yes.
So
Yep.
I'll wait till that. And I follow up with these patients almost every 2 to 3 days,
Yeah.
consistently checking pressures, really, really checking the pressures,
Hmm.
making sure there's no other like side effects
Yeah.
or
Same.
whatever, and checking VAs just to make sure the vision is
Yeah.
stable. But yeah, I think that was the other issue with me and this other optometrist. We started tapering too soon, and then we were like,
Yeah.
oh, should we have tapered? And then it would come back, and we are
Come
like,
back.
oh, now it's
Yeah.
worse. We got to put her back every like 2 hours. So
Yeah.
I was like, you know what? I'm just gonna take over this patient. She's just gonna see me now because it's just better if one doctor sees her because I have no
That's
idea
true.
what's
That's
going
true.
on.
Yeah.
And I was the first one who saw her in the first place, like from the beginning, so she was like okay with that. But yeah, taper when there's zero cells and flare. Don't taper too
Yeah.
early, or otherwise it's just gonna
You're
bite
gonna
you
regret it.
in the
Mm-hmm.
butt. Then you're
Mm-hmm.
just gonna see these patients
Oh
constantly
yeah.
more for follow-ups. So yeah, I wanted to talk more about the lab testing and the
Mm-hmm.
diagnostic workup. So in Alberta, Canada, the optometrists do have the privilege of ordering lab tests for themselves.
Mm-hmm.
So as long as you're able to interpret it. So here, I practice in Alberta. I can technically order lab tests for my patients. I don't because that means I would have to interpret it. But I'm very willing to work with a family doctor
Yeah.
and maybe send them a letter saying, these are the tests that I would recommend for the patient's lab work
Mm-hmm.
uh, for them to do. And then going over the results together, you can let me know like what's
Yeah.
going on as a co-management thing. I think a lot of family doctors would be really open to that, I would
Mm-hmm.
hope. But yeah, in Ontario, you guys can't
No,
order.
we are not allowed to order lab work
Yeah.
as optometrists. It has to be, we have to make a referral to their family physician who will get it
Yeah.
done. And actually, yeah, that reminds me, tomorrow I have a call scheduled with one of my patient's rheumatologists who,
Oh,
yeah,
yeah.
again, this was a patient who's had a recurring uveitis like almost 100 times over. And
Yeah.
he's already been diagnosed 20 years ago with Crohn's. And
Oh,
so, he just kind of assumed, well, yeah, I have Crohn's. I have an autoimmune condition. And so this is why I get my uveitis. And so we've seen him over and over and over again for like 5 years. And
yeah.
he mentioned that, he never had a uveitis until about 5 years ago. And now,
Oh,
ever since like 5 years back to now, it's the frequency has been increasing. So I asked him a few times before, did you get updated blood work? Do you have any other autoimmune conditions? No, I haven't really checked. I don't see my rheumatologist anymore because my Crohn's is like,
oh,
fine. Everything is fine. And then he's like, I'm getting a little bit of joint pain, but like that's after I run for like, 2 hours. So that's
Yeah.
normal. Okay, fine. And then I finally pushed him. I said, dude, you gotta just get the blood work done again. And I got a letter from the rheumatologist saying he's positive for HLA B27.
Mm-hmm.
But again, we know that that marker is it's non-specific. Like we
Mm-hmm.
don't really know what diagnosis it could be related to. So technically it could be related to Crohn's.
Mm-hmm.
However, with the joint pain, then they started asking more questions, and now I think they're going to do more testing and look into some level of arthritis.
Yeah. Because
And
that's what,
so,
yeah, that's
yeah. And
exactly what
so the
HLA
rheumatologist was
B27.
telling him, he's like, you might have another underlying
Yep.
condition we have to look into. Patient called me thanking me, like, you're the only doctor who has seen me for this uveitis, telling me to go get blood work. And now I'm getting answers for like other things that have been
Yeah.
going
I
on.
think,
Like, no one has brought this up before. So it's very interesting. I'll talk to the rheumatologist tomorrow they want more
see,
detail of the level of the uveitis. They said if it's sight threatening, then they want to start him on some immunobiologics.
yep.
If it's
Yep.
not sight threatening, then they're just going to monitor him. And
Yeah.
the last one, he had a CME. So that's why now it's like,
Oh,
dude, all your uveitis cases have been pretty
severe.
straightforward.
Yeah.
And then the last one was a
Was
CME.
severe.
So I
Yeah.
was like, okay, it's
No, this
time.
is
You
just
got to
so
figure it
there's a
out.
pattern of it becoming worse. So, I
Yes.
mean, like, I think again, in school, we're taught like, okay, if it's the first time for the anterior uveitis,
Yeah.
you don't necessarily have to do blood work. Okay, fine, right? But you should do the blood work
Yeah.
or talk, have this discussion if it's reoccurrent, chronic, if it's
Yes.
in both eyes, even
Yes.
the first time, both
Yeah.
eyes,
Oh,
yeah.
yeah.
Obviously, we already talked about this. If it's granulomatous, yes.
Hmm.
And if it's non-responsive to treatment,
Yes.
or if you're seeing it in a child for the first time, you got to
Yes.
get that blood work done.
Hmm.
So there, like now the question is, like you already kind of did this. You talk about what their history is like. Oh, are you feeling pain anywhere? Because it could be some sort of autoimmune condition.
Hmm.
That's where you have to ask more questions. If there's patients, like the patient I was co-managing with this other optometrist, I asked her if there was any systemic issue. She's not on any medication. She's not on
Yeah.
anything. There was no significant history or systemic physical findings for her. Um, why she was getting now this reoccurrent uveitis. And now I'm like, yeah, girl, we got to get some blood work done. I got
Yeah.
to send a
Just get
letter
it
to your
checked.
family doctor. Um, and suggest some, like a diagnostic workup.
Hmm.
The question is now, like, what do you ask for the family doctor? Because one time when I early on in my career, I just sent the doctor, like the family doctor, blood work needs to be done because this patient is getting a reoccurring uveitis. He sent a letter back to me and he was like,
It's like, what blood
what
work?
what blood work? Like, what do you want to get done? Like, what needs to be done?
Yeah.
And then I was like, dang, shouldn't you know this already? I was like, maybe I should know this. So
Yeah.
I think like a good start out point is you're gonna start with the CBC or the
Hmm.
complete blood count, right?
Hmm.
That's what you're gonna start with as well, and then the complete metabolic panel. Then
CMP. Yep.
yep. And then HLA B27, because that's gonna
Hmm.
rule out what is ankylosing
Hmm.
spondylitis, reactive arthritis, all the arthritises, and then Crohn's, like any
Hmm.
inflammatory bowel diseases. Then you wanna maybe consider ACE or the angiotensin converting enzyme
Hmm.
for sarcoidosis. If you suspect that, like that's like an instant referral because
Yeah.
there's other things that need to be done, like a chest
Yeah.
X-ray and like a chest CT possibly. Rapid plasma reagent is for syphilis, but again,
Hmm.
that's a more infectious condition. And
So
then in
for
children,
for the
definitely,
big ones, sorry, for the big ones like sarcoid and TB,
yeah,
I usually have that written in my letter as
yeah,
like an additional add-on if the doctor um suspects it. So I'll say,
yes,
here's all the lab
that's a
work
good
I
point. Yeah,
recommend you do. Please include chest x-ray and PPD and whatever for ruling out tuberculosis and sarcoid if you suspect based on
Mhm.
patient symptoms
Yeah.
or questionnaire that they need more. So I'll
Yeah.
write it so it's kind of in the doctor's head, but I'm not always pushing for it like, the like right away.
Yeah. And I
Because
think
I
like
sometimes don't know like, yeah, what other symptoms would I be looking for other than like difficult like coughing, chest pain, difficulty
exactly.
breathing. Yeah.
And yeah, so that's a good point. You don't have to say the specific tests. Like I feel like the family doctor will know, but just mentioning the
Mm-hmm.
overall conditions will be helpful.
Yes.
And I feel like HLA-B27 is the one that's missed quite often.
Yes.
So just with standardized blood tests,
Well,
they're always
and
going to do,
thyroid levels.
yeah, and thyroid
Bring
levels
thyroid
too, right?
level. I think that one's often missed because we don't
Yeah.
keep in mind as much that thyroid disease is autoimmune, so that can cause a lot. I mean, that I have Hashimoto's thyroiditis, so I had my first uveitis like 3 years ago, and
Yeah.
and that's when my thyroid levels were really not well
Yeah.
controlled, so that can cause it as well.
Yeah. So yeah, talking about
Hmm.
thyroid levels as well or thyroid testing.
Yeah,
And also like especially in kids, you want to definitely consider the rheumatoid
yeah.
factor to rule out or rheumatoid factor or
Hmm.
ANA to help rule out juvenile idiopathic arthritis because
Yeah.
that's if you're seeing uveitis in kids that needs to be
Oh yeah,
handled very
needs to be checked
quickly
out. Yeah.
because yeah that could definitely lead to other conditions but that's a good starting point like I think if you like if you're gonna request blood work, just sending that letter to the family doctor so it gives a starting point for the family
Hmm.
doctor, especially if the family doctor is like, I wasn't expecting any of this. Like, what's
Yeah.
going on?
Yeah.
So they can order that and then send a report back to you, and you guys can kind of co-manage this patient together to see
Yeah.
what's going on. Yeah. So,
That's a
uh,
good summary.
yeah,
I'm glad we went
I'm
through
really
those
excited to
cases.
see when I
Yeah.
send that letter for that reoccurring patient what happens because she literally is like, I don't have anything wrong. Like I don't know
Yeah.
what this could be. And I'm like, nah, girl, we're gonna do some blood work. So I was like,
Yeah.
so I know what I'm gonna send to the family doctor and I'm really curious to see what comes back. Um, yeah, I mean, if it's all negative, I feel like I've heard that the HLA-B27 can be negative
Yeah.
in
Yeah.
certain times if
Can
you have to
still,
do it
yeah.
repeatedly to find that positive
Which is,
sometimes.
yeah, which is why I highly recommend if you have a recurring situation again and they've already done blood work before, just have them do it again. Even if it's
Yes.
3 months later, 4 months later,
Yes.
your body changes. It does not stay exactly where it was like
Yeah.
5 months ago. Everything changes every day. So just keep getting them to check because you know, there's always some underlying stress that's going to cause inflammation and it's not only affecting the eye, it's going to potentially affect other organs too. So most of the time you'll find something if you really
Yeah.
look for
And
it.
even if it's not finding something, it's not something that I'll give
At
up
least you've
on. I
done
feel
your
like,
due diligence to make sure
yeah. And
it's
it's
been
just like
checked out.
doing everything you can to figure out why.
Yeah.
Because as we all know with the eyes, it's all usually coming like any kind of
From the
symptoms we
gut.
get. No, I mean, yes, but it's also all systemically related. Everything's
Yes.
connected, right? So,
Mm-hmm.
um, you got to find, you're trying to get to the root of the problem, right? So,
Yeah.
yeah. So I just
This is
wanted
a
to
good
give
case.
that basic overview of these, a few of these cases, because I feel like sometimes when we're so wrapped up in clinic, we forget the, you
Mm-hmm.
know, like the ABCs of
Yeah.
uveitis, and we're just kind of like, what are we supposed to do? What are we supposed to order? How do we grade this?
Yeah.
And, charting for uveitis is so important too. Like we talked about, the
I
blood work
definitely
part is talked
learned
about.
like the flare tip, like because I
Yeah,
always grade flare as like trace or +1, but now I'm gonna pay attention to can I see the iris and the lens details
yeah.
because
And then
that's
even like
so helpful.
everybody gets a red eye in their clinic. That's most of our
Yeah,
emergencies, and just making sure that you don't make the same mistake as I did, where you're just kind of, okay, I think
making
this
an
is dry
assumption.
eye. Like, let me just find the dry eye signs, which I did.
Yeah,
But it's just keeping your mind open and thinking all the
all the way
differential
through.
diagnoses and being
Mm-hmm.
like, okay, it could this be uveitis? So as you
Yeah,
practice more, I feel like you kind of forget all these things, but
yeah.
it's
Good
good
reminder.
for good for patients to come back and be like, it's still there. And you're just like, no, leave me
And then
alone.
for anyone listening, if you're a long-term listener, we've done case reflections over the past few years. Deepon has shared a different uveitis case a couple years ago that was related to like a tattoo that a patient got. And then Rav,
oh
our
my God,
previous
make sure you ask if they got any new tattoos.
Yes, yeah. And then Rav, one of our previous co-hosts, she also had a case reflection episode of a chronic uveitis that was getting worse, and then she had to like adjust her treatment. For anyone that's new that hasn't listened to those episodes, I'll put links to those episodes in the description box so that you can kind of listen to those as well. And then I haven't even listened to them in a long time, so it'll be interesting to see how we've evolved with our approach, because I'm sure it hasn't changed too much. But now you've evolved. You ask about tattoos because we never did before. That tattoo
one traumatized me because I was in my first year of working, and I will never forget that one. She was the first patient I got that I was like,
the tattoo was traumatizing in your case, and then in Rav's, it was the tapering early.
Yeah.
Right. So that like she tapered too early, and then like things got really bad. So I highly, highly recommend you guys scroll all the way back, listen to those case reflection series on uveitis. If you enjoyed this episode, please DM us on Instagram at 4eyesOptom. Give us feedback on the episode topics. I did ask on Instagram, on my personal Instagram, if people had an interest in some topics, and people did give feedback, which is great. But feel free to always DM us on Instagram and give us more topic ideas of what you'd want to hear, what you'd want to learn from us. Because we always think we're losers and like not relevant. So like, I don't know if people really want to listen to us talk anymore. But yeah, and the case reflections are always good because it's a good learning lesson for both of us too. So we hope you guys really enjoyed it today. Thanks everyone for listening to Four Eyes, the podcast series brought to you by Young OD Connect. Be sure to subscribe, follow us on Instagram or YouTube at 4eyesOptom for more content, and we will see you guys next time.